Good evening, and welcome again to Public Perspective. I'm your host, Kevin McDermott, and if you follow the news, you'll know that today in America there is a growing problem with drug use, hard drugs, heroin and opioids. So our guest tonight is Kathleen Kane-Willis, who is the Executive Director of the Illinois Consortium on Drug Policy at Roosevelt University, here to talk about the epidemic and how it came about and what we should be doing about it. Kathleen, welcome to the show.
Thank you so much for having me here. I'm really excited about this.
Well, let's start with some basics. What is the consortium, and how did it get started? Why is it at Roosevelt? How did we get here?
So I worked at a public policy research institute at Roosevelt called the Institute for Metropolitan Affairs, and then in 2005, I started a project called the Illinois Consortium on Drug Policy, and it's become its own institute. Because I'm really interested in this subject. And in 2004, we had released a report that showed demographic shifts in heroin and opioid users, specifically heroin users. Basically, the idea that heroin use was spreading to demographic groups that were considered unlikely candidates: suburban, women, and
affluent.
Affluent. And white. And we'd always known, of course, there were white users. When we saw this pattern emerging, we thought that it might be a problem down the road. And we were correct in that. That report in 2004 received a ton of publicity, but I think that, that most people were not aware of it really being an issue.
In fact, when it arose as an issue in, correct me if I'm wrong, New Hampshire, was it?
Well,
the governor came out and said this is a major problem.
In Vermont, Governor Shumlin devoted his whole state of the state. Yes, I mean, there's been the opioid crisis, and that's, when I say opioid, that's a proper word, so opiate, prescription pills, and then heroin. They are intertwining at this point, but back then, in Illinois, we don't have those kind of prescription drug prescribing practices that many other places in the country do.
You mean they're looser here? Or
they're more
tighter?
strict. Yes. Okay. So our per capita rate of, say, OxyContin prescription was very, 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 very low. But that doesn't mean that Indiana and Missouri don't have high rates, and
it
borders
bleeds over the borders, right?
Yes, exactly. That's right. But heroin had always been here. It never really went away. But in 2004, we saw this demographic shift, and we started thinking about how drugs were transferred. Like, for example, transmitted, or how that information, or suburban and urban issues, and that these were much more porous than what we had previously thought. For example, I'll say raves with MDMA, ecstasy, right? That was an urban phenomenon that became a suburban phenomenon, and then became both. You know what I mean, right? And so we knew that this had the makings of something that looked like it was going to grow pretty exponentially, and that's exactly what we've seen, is a J curve.
Now, I have to go back to 2004. That seemed like a fairly prosperous time in the United States. It was prior to the financial meltdown by several years.
Sure.
The economy had more or less recovered from the dot-com implosion.
Right.
Yes, the September 11th had happened, but what was it about that time period that might have caused this shift? Well,
I mean, I think we looked at indicators from 1996 to 2002, when that report was released in 2004. So it's actually picking up prior to that period. So the numbers were not large, right? But you could see this pattern emerging.
See the trend.
The trend, right? So, and the way that we looked at that was by using sort of novel methods, and the Substance Abuse Mental Health Services Administration, not novel, multiple indicators. So instead of looking at just, say, treatment data, which there is no repository, there's no place to put all treatment data. Like, if you get treatment privately, we don't know what you've entered treatment for, but all publicly funded treatment we can track, right? But then we think.
But that should be a fairly good proxy for what's happening in the population at large, right?
Well, yes and no. It's a good indicator. One indicator is never a good. Nothing is they're subject to like how much treatment is available, who's using it, where it is, income requirements to enter. You know what I mean? So criminal justice referrals could be something that could be driving treatment admissions. So it's one place to look, but what we did was we pulled a number of different indicators, including some law enforcement, some hospital discharge data. And hospitals are kind of equalizers, right? Everybody is going to go to the hospital. And so when you see patterns emerging from hospital data with these other components, you can say, oh, maybe this looks like a trend.
The hospital data is publicly available? I mean,
it's not.
Not with patient names, but
no. This is aggregated
data,
right? So you can't see like who entered the hospital. No.
Right.
In fact, in Illinois, it's very difficult. There's a suppression effect. So if there's fewer than, at that time, I think it was 8 cases, you got nothing. So you had to make sure that you asked in a way that you got data in all of the cells. So if you wanted to look at race and gender and age and all these things, a county, you wouldn't, some counties would just be suppressed. And so you want to make the groups large enough so that you can see it, but small enough so that you can have the detail to say where it is happening.
Right.
So it's a little, it's, it's that you're looking at, and then you have to understand what the suppression factor is, and then you have to piece it all together and come up with what you think is happening. And I think people were very surprised about that. I think Northwest Indiana the newspaper spent about a week after the report came out revisiting the entire issue. I mean, it was such a big deal. But the state of Indiana did not take notice.
So, still brings me back to my question, though, even though the data is from 96 to 2002. I don't know, maybe you didn't look at this. What were the underlying?
First of all, I think there were a couple. There was not toes, shoes,
Any kind of fashion or music for that matter.
Right, exactly. I mean, I think you see that it's starting to be, and then it becomes more, and then it's more and more and more, and then
pretty soon it's cool. If you're hip, you want to try it.
Right. Well, I mean, it's hard to, but it's that kind of, yes, it's more, I think, I look at it as more of a social phenomenon, and I don't think we were doing any education around drugs. I mean, if you think about that period of time, Red Ribbon, DARE, which was ineffective, and I would say 2005, around that time, I started to present the idea of like, can we have a discussion about opiates and heroin in drug education? And if there had been rotten fruit in the room, people would have thrown it at me.
Sure. So, well, I'm surprised by this, and one of the things that it brings up is that when I was in college and everyone I knew was taking drugs right and left, most of the information from so-called trusted sources was not trusted, and the famous movie Reefer Madness, which was a propaganda film that we used to laugh out loud at, and so there was a lot of discounting of what was official line, because much of it actually was false. I mean, the idea that smoking a joint is suddenly going to make you turn into a crazed, axe murderer just wasn't true. So is that some of what happened here?
I think so. I really do. I think that in the 80s and the 90s, you really got that again in a much bigger way. And so when you're looking at survey data, and that most high school students about 40%, depending on what time it is, have tried, say, marijuana. And if you say this is going to lead to your death, right? Or give, you're going to get AIDS because you're going to make a risky decision, or this poor choice is going, usually it's like leads to death, destruction, disfigurement,
People just
HIV.
didn't believe it.
Right, and so if you're not talking about drugs and drug classes, like why would you? So if they're lying or not giving correct information about, cannabis, marijuana, you know,
Then why should I trust this other information?
Right. I mean, but they weren't even really talking about it. So I think some of the things that we picked up in our research was that this was just another drug choice.
Mm-hmm.
Do you know, so
and not differentiating between the fact that marijuana, which is becoming more and more legal around the country, which is not nearly as harmful as something like heroin, that there is a distinction. Whereas, and I don't mean to put words in your mouth, but it seems to me that there was this conflation of all drugs from marijuana to mainlining heroin are equivalent, and in fact, they're not.
Well, no, they're not, and I mean, it's right. There's many differences, but drug education programs said alcohol and other drugs, and if they talked about other drugs, it was alcohol, tobacco, and other drugs, ATOD, right, is the acronym for it. And the other drugs was marijuana. So there really was no discussion about drugs, period, you know, so except that they were bad.
All of them.
All
uniformly
of them.
Bad. Don't even think about any
bad,
of them.
right? So I don't know that there was enough knowledge for people to understand what is dependence, what is addiction, what is that? I mean, if you say that you're going to become addicted, like say, if you use marijuana and this would, you know, maybe fit within substance use disorder, like you use every day, it might not be, substance use disorder might be mild, but you know, that you're going to become addicted. Well, what does that mean? Should you stop? I mean, it's probably not interfering with your, it could not be. It could not be. Who use marijuana? It's one of the drivers, but that's what's possible. Yeah.
With affluence, you mean that there's too much leisure, there's too much money, people get into trouble.
So it could be that there's the idea people live in bigger houses, they're more isolated from one another, their family members might be really busy, they might have very high expectations put on them. They don't have connectedness to things, you know, to a sense of purpose or place, or, you know, I'm doing the really bad thing, right? This is probably horrible for TV.
Think about
but if you think about a J,
right.
if you look to like going up,
right.
and you know, I was when you show them what
sometimes if you are convinced of something and you see numbers that don't support that, many people have the first of those were gathered, or the analysis may have been incorrect. So I think it's easy to reject that.
It was, so the way that they were showing the data was heroin is a percentage of total treatment emissions. It's small, like at that time it was a small thing. You can't see that growing over time in the same kind of way than if you separate all of the drugs and look at the number and calculate a percent change, which you would be able to pick up on the upward curve.
And this is what we're talking about, seeing the admissions for heroin
right,
abuse,
like so there's a period where you can see that it's going up, and if other things are not going up, you know, then you have an indication. And then, you know, not very long ago, I mean, Indiana had a state of emergency declared. They had to bring in, you know, syringe exchange. They had an HIV cluster. So I mean, we had recommended that they started syringe exchange programs back in 2005. I think that in a way it was very easy to say, oh, it's Northwest Indiana, you know, by Chicago, that's the problem. But I went back and I looked at, you know, a number of different counties. It was just shocking how much opiate problem there was. And we knew opiate to heroin transition was going to be a problem. The other thing is the demographic group that changed white folks very quick to start off snorting and then transition to injection. African Americans much less likely to inject from the data.
Interesting.
Probably because of
greater cultural awareness that this is really bad. We know the consequences.
Right, the HIV epidemic in the community, and so there's more stigma associated with it.
So what's going on in Illinois? Is this being recognized, and is there action being taken to try to correct the course we're taking?
Yes, Illinois is now aware, and so, you know, that incident where people wanted to throw rotten fruit at me, I mean, I'm not joking, it really was very, very uncomfortable, intense.
And who's the audience for that again?
It was drug counselors and prevention people.
And they just weren't
They
accepting
didn't want to
this.
hear that because they thought if you mentioned the word heroin that, or if you talked about the relative